This is the lab prep for thorax and lungs. So the structure and function of lungs is important to understand and be able to identify the anterior landmarks, posterior landmarks, and the vertical reference lines. So on the anterior, we look at the horizontal landmarks as the clavicles and the vertical landmarks as this complete sternum from the suprasternal notch all the way down to the xiphoid. We also include the sternal angle and the costal angles when we're looking at the AP to transverse diameter. As you know, you have 12 pairs of ribs and there are spaces in between each of those ribs. The posterior landmarks include the scapula on either side of the spine, and the vertical landmarks are the vertebra prominens, the C7, and the spine itself. We look at the vertical reference lines, anterior, posterior, and lateral, to identify the upper thorax and lower thorax. If you look at these structures on the picture, this will help you visualize because the skin on the outside is going to be different for each patient, but we anticipate the thoracic cage is going to have some type of structure or framework that we can follow. As you can see, this red line here shows you where the diaphragm is located. So it would make sense that since the diaphragm is the floor of the lungs, that if you're listening below the diaphragm, you're not going to be able to hear the lungs as well. So think about that as you are assessing your lungs. We know that on the anterior part of the chest, the apex is located above the clavicle, and the base is the lowest border of the diaphragm, is at the 6th intercostal space, mid-clavicular line on each side. So the lungs start at the top and work their way laterally. So be thinking about that. The heart is more central and the lungs work their way laterally. When we're thinking about the lateral auscultation places, think of the apex is in the axilla and the base of the lungs is down to the 8th intercostal space or 8th rib. So in the posterior, when we listen to the lungs, we start below the C7, which is the apex, and we go all the way down to the thoracic 10 space, which is the base of the lungs. So you can see with the pictures kind of where everything sits. And also remember, there's 2 lobes on the left side and 3 lobes on the right. So when we're preparing the patient, we know that we're going to have to assess the entire chest, but we're going to drape the patient, especially for females, because we're going to have to listen around breast tissue for the anterior part of the chest. We want our patient to sit upright and have their arm relaxed at the sides. You're going to give the instruction for the patient that every time you place the diaphragm of the stethoscope, that they're going to breathe in and out, and you're going to listen to the inspiration and expiration. And always be sure to clean your stethoscope with alcohol before you touch your patient. So when we're inspecting, we're looking, we're observing, we're looking for signs of distress, like nasal flaring where the nares flare out, any pursed lip breathing, which means the patient's trying to control their breathing, or use of accessory muscles like shoulders and intercostals. This should not be happening. Your patient should not be having respiratory distress. These problems can be related to COPD or congestive heart failure, but obviously that's a concern. We're also looking for central and peripheral cyanosis. So looking at consistent color to the face, lips, the chest. We also look at nail angle. We know that an angle of greater than 160, which means the nails kind of curve around the tip of the fingers. We see that clubbing in patients with chronic hypoxia. We look at the shape and configuration of the chest, the thoracic cage itself. We know that patients who have a barrel chest or increased AP diameter, that can be related to some chronic hypoxia as well. Some other things that might impact the patient's chest expansion are lateral deviations like scoliosis. If we know the scapula is asymmetric, which we see in scoliosis, or if the spinous process is not straight, this could be impact the patient's chest expansion. So we look at their midline sternum, and it should be midline and straight. And we're also observing, lastly, for respirations. Is your patient's respirations even and unlabored? Is the rhythm within range, the 10 to 20 range? Now, you may not be palpating your patient all the time, but if your patient does have tenderness, we are going to need to validate that tenderness. So I always ask if there's any chest discomfort or pain. We would expect there to be no tenderness, no masses, no lesions, no discolorations or anything like that. Any muscle soreness or increased warmth can be related to some type of injury. And we see that tenderness and pain with rib fractures from osteoporosis, those type of things. Now, if the patient has had maybe a thoracic surgery, chest tube, a tracheostomy, or any areas of a significant consolidation in the lungs, sometimes the air escapes into the subcutaneous tissue. And when we palpate that, it feels like a bubbling underneath our fingers, or what we call crepitus. Now, when auscultating, again, you're going to clean the stethoscope. You're going to go side to side. You want to compare upper thorax to upper thorax, scope to skin. And as your patient's taking deep breath in and out, as you move your stethoscope to each place, you're always going to watch and make sure they're not getting short of breath or fatigued. So on the anterior spaces, you're going to start below the clavicles to assess the upper thorax or apex of the lungs. So 2 places in the upper thorax and 2 places in the lower thorax. Be sure that you're not listening over breast tissue and you're listening for full inspiration and expiration. In the posterior spaces, you're going to have the patient lean slightly forward and again, having the patient take deep breaths in and out. We are not going to listen over bone. You're going to listen to the inspiration, expiration to the vesicular lung sounds in the back. Using that diaphragm, and you're going to begin below C7, which is the apex, and go all the way down to T10, but not over any bone. So we kind of do a backward C motion. Now, when you're listening to the lateral lung sounds, your first position's in the axilla or the 3rd intercostal space, and you're going to move down to the 7th or 8th intercostal space laterally. So in this picture, here are is a review of where everything is. So you can see each lung space and what you are listening to. Now, in this picture, there is the exact exam placement. So, in the anterior and posterior. So here in this picture, there's the posterior. You start below the C7, and you are listening to those spaces 1 and 2, 7 and 8, and 17 and 18. Kind of makes a backward C in this picture. Now the next picture, you are listening to 3 and 4 and 9 and 10. So this gives you exactly an idea of where you're going to listen. Now, there may be a few conditions that we see. We are in prime respiratory diagnosis time. So you may see these in the hospital setting as well. So understanding pneumonia, bronchitis, emphysema, and COPD, asthma, atelectasis, which we know is a collapsed section of the lung, and heart failure is going to be important for you to be able to assess and know some of the findings. So be familiar with some of the things that you might expect and why for the patho for these diagnoses. It's just going to help you in your clinical setting.